Kia ora, everybody. This is the first of the popcorn panels, which you've probably figured out by now. I noticed we just got a message from somebody who's already finished their popcorn and has started on the wine, which is fine. So my name is Barbara Fountain, and I'm editor of New Zealand Dr. Rata Aotearoa. Welcome. The popcorn panels are a place where we can get together and have a chat with people who know their stuff a lot better than we do. Tonight we're going to be chatting about the Simpson report and specifically what it means for PHOs. I'm having to read my notes now because I was a lot better prepared like 15 minutes ago. So please sit back and relax because there's no quiz at the end of this webinar. But we are going to throw you a few poll questions, and we're just going to start with a quick poll now while I explain how things are going to work tonight, just so we can see who's actually sitting out there. So while you're doing this poll, I'll just explain how we hope this might work. I will start with a few questions to our panellists, and you can post your own questions in the Q&A. You can also make comments in the chat stream. We'll be saving those comments at the end of the session, so and possibly using them for editorial coverage. So please don't put anything in there that you don't want to see in the headlines. Also, we will be recording the session for possible use later. So if anyone misses it, they'll be able to check it out later. Assuming we do an okay job of it, so we'll be cutting the first 15 minutes. On the team with me tonight are Zara, Martin and Tyler, all here from the health media. They'll be watching for questions and comments, and they'll be able to answer any problems you might have in chat. Please post a note if we suddenly disappear, because that is not part of the plan. Now to our panellists, so I'd like to welcome Jackie Cumming. Jackie Cumming is a health systems researcher from the Victoria University. Jackie has been researching PHOs for well over 20 years, well 20 years actually when they first started, and in his recent years has been looking at primary care models. So Jackie's coming to us from Wellington. Also down in Wellington is Martin Hefford, Chief Executive of To Order Compass Health. Martin has wide experience in both DHBs and PHOs, and last year spent some time travelling around Europe looking at different primary care systems there. Recently, Martin wrote a paper with Helen Parker from Pinnacle looking at proposing a structure they would like to see for the system, and maybe we can talk a little bit more about that later. And coming from us from down in South Canterbury is GP Bryan Moore. Bryan's in the unusual situation of living in an area where there is no PHO, and the GPs down there had a vote of no confidence in the PHO in 2013. And since then, the DHB has handled all the contracting matters that would normally be done by a PHO. So we're kind of interested to hear how Bryan feels about the possible disappearance of PHOs, and also most likely the disappearance of his own DHB. Bryan does chair the South Canterbury Primary Care Alliance, which does the negotiations with the DHB. So welcome to you all, and I'll take a bit of a breath and say, so when the Health and Disability System Review was announced a couple of years ago, I know that there are a lot of people in the sector who are really keen to see change. I mean, everyone was looking for change. Everyone kind of accepted that what we were doing at the moment really wasn't working. It wasn't producing the best outcomes for patients, and it certainly wasn't performing in terms of equity of outcomes. So today we're looking for even more of a wow moment. That's what I like to think of, a wow moment. And because nature has dealt its own wow moment with COVID-19. So the question is, does the Simpson report deliver that moment for health, for patients, for equity, or as we're going to discuss tonight, for primary care? And pushing PHOs aside and inviting localities to the party, is primary care going to be any better off? So my first question goes to our panellist Jackie down there in Wellington. You've been studying PHOs off and on over the last 20 years, and I just wonder, they haven't been totally dismissed by the Simpson report, but would we miss them if they were?
Well, kia ora. Hi everyone, great to have you all here, and thanks for the invitation and organising all of this, Barbara, because I think it's really important. Would we miss primary health organisations? I guess yes and no, and I don't think some of the functions that they're actually performing are actually going to disappear. If we suppose that the Simpson report is implemented as it's actually written, and DHBs take on the role of organising and planning primary healthcare in their in their districts and then organising localities, they're going to need another partner on the other side who they're actually doing the negotiations with. And to a large degree, that's PHOs at the moment, and some form of organisation like that would still need to be there. An individual DHB or even Health New Zealand, if it took on the role, wouldn't be able to have contracts with every single general practitioner and other primary healthcare provider in the country. So there's got to be something there that's actually representing local primary care providers and doing a lot of that work around allocating the funding, you know, technically, so it comes from the DHB through to individual providers.
So when we spoke earlier, you mentioned that one of the problems with PHOs that you had with the dismissing of the PHOs, I suppose, is that we haven't actually really figured out what they've been doing that's been really good or really bad.
Yes, I think one of the issues in relation to the report is the lack of research that underpins that role of the PHO and the alliances to some degree as well. One of the issues that's been there almost right from the beginning of the primary healthcare strategy is what is the role of the primary health organisation? And there are different views around about what that is in terms of how strategic it ought to be, how, you know, if it's, who it's representing, how far its scope of work actually kind of goes. And because we haven't properly had that discussion, it's quite difficult to say, well, they haven't actually worked. So yeah, if we have had a bit more kind of research underpinning some of those recommendations, we might have had a better idea about what parts of PHOs do we really need to continue and how do we make that happen.
Martin, in your proposed model for the health system, you placed integrated care organisations at the middle and put hospitals off to the side. Looking at that, I feel like you're investing a lot of power in primary care to actually, those integrated care organisations to actually manage the wider health system. Do you feel there's the evidence to support that out there now? Martin?
You're on mute.
Sorry.
Kia ora koutou katoa, there it is.
Yep.
Rookie mistake, straight up. Look, so one thing I would say is that if you didn't have PHOs, then I think you need to invent something else to be the organising function in primary care. If we want multidisciplinary or interdisciplinary primary care organised across providers without a single employer, which is the nature of what the review's called Tier 1 services, then you need someone to do that integration. And yeah, Helen and I talked about integrated care organisations. It doesn't really matter what you call them, but you need something that isn't, preferably isn't provider specific, that can organise service delivery for the benefit of the population. And yeah, so there's a comment.
Yeah. So isn't provider specific? One of the, I mean, I think you pointed out that the Simpson report's pretty light on actually what localities are going to be, and whether, although it's quite a large table there which explains what they will provide. As the chief executive of a current PHO, could you see yourself your PHO moving into that kind of locality business?
I do see us moving into that business, whether the kind of Simpson report comes true or not. I think that there's a real strong need for that stitching together pharmacy, general practice, midwifery, district nursing, physiotherapy, all of those services, so that people are not bounced between them, but they offer a coherent team approach. And I think that's one of our jobs, is to make that happen. I think we've been handicapped in the last 18 or 19 years, however long it is, by only ever having been given the funding around general practice. There's a little bit of implied criticism, PHOs have been very GP dominated and GP oriented. And it's true, but it's because our contracts do not include midwifery, and they do not include physiotherapy, and they do not include pharmacy and so on. And so I don't think PHOs have really ever had a chance to fulfill that broader function and mandate.
So Bryan, down in South Canterbury, where you didn't have a PHO, Did the DHB manage to bring in other primary care clinicians into the kind of primary, in a more integrated manner with the GPs?
I think that we have you've got to first understand why we have no PHO in South Canterbury. Fundamentally, the PHO went out of existence because GPs felt that it didn't adequately represent them, and that the PHO also went out of favor with the DHB because it didn't adequately represent the DHB to GPs. In other words, it didn't bend general practice to its whim as it saw it at the time, and was fairly antagonistic towards general practice. And so, unfortunately for our PHO, it was the meat in the sandwich. And so with two sides feeling unrepresented or by it, it ended up being gone. There were a lot of teething problems, shall we say, some of which ended up in front of the High Court. So there are those processes. I do think, however, that fundamentally from the start, PHOs were thrown under the bus. They were never given a clear direction about what the intention was. There was never any plan about what the healthcare system should look like in the future and how PHOs were expected to achieve it. It was just kind of, yeah, make it up as you go along. And in fact, the Minister of the Health at the time, Annette King, said that, oh, we're just going to try this and see what happens, which is not a strategy. You know, it's a statement, but not a strategy. And when you blame PHOs for those failures, or you produce a Simpson report that somehow passes that failures on from DHBs and PHOs onto those organizations, it's unfair. The basic fundamental issue is that no authority rests in PHOs, no authority really rests with DHBs. That authority has always rested centrally with ministry, and ministry hasn't known what it wanted to do in the first place. And no matter how you rearrange the deck chairs on the Titanic at the moment, you're not fundamentally going to address that. So what we have tried to do in South Canterbury, and it does come around to, if you want to contribute, you've got to have skin in the game. And are you prepared to invest your skin in the game, or do you just want to tell how the game goes? And that's been fundamentally the issues with things like community pharmacy, etc. They want to say in the process, but they aren't prepared to put any of their funding into the pool. They want a share of the funding that we have, which is very limited, and recognize that PHO funding for what we receive, you know, at 1.46% of government health spending going into primary care, it's abysmal by anybody's standards. You can't expect to have a system that is going to have equity and equality within it when it is so poorly funded, when in fact the funding is coming from the patients. So whilst we've tried to include, and we on a regular basis with our meetings take reports from NGOs, from physiotherapy, from the radiology, the fact that we work really closely with the DHB means the DHB gets to coordinate that. And we're fortunate in having a DHB that's really community focused. So at the moment, so this is for now, I mean, even if you look at our representation on our DHB board, there's a significant health input from physiotherapy, from community pharmacy. I mean, our chairman is a community pharmacist. We have 2 physiotherapists on the board. We have a former associate minister of health on the board. We have a GP. We have a retired orthopedic surgeon. I mean, we've got a spectrum of people involved in the community that we're trying to evolve something that will improve access to the health system for all the people involved. And I can't really see that happening elsewhere.
And the irony is, Bryan, is that all that's going to disappear if these patients go ahead. So I'm just looking at some of the questions that are coming through, and one of them is one that we slightly touched on before, and that's given the 2 people have asked about this, whether the panel, what does the panel think about turning the funding model around and having the funding sit with primary care, who then contract hospitals to do what they require? And those of us who go back long enough in the system will remember back in 1990s, I think, with Bill English and the integrated care proposals around Wairau and Wanganui and Tauranga, that we got kind of close to something like that. And I think, Martin, your model would look closer at that approach as well. from your experience in Europe with the models you looked at, is that, is that the well moment that we actually put primary care in the middle and get them in charge of the funding?
What I would say is the risk with the Simpson report recommendations, one of the big risks I see is a hospital-dominated system and a continuation of hospital-oriented policy and hospital-oriented decision-making. And currently our funder is also responsible for the hospital balance sheet and for employing thousands of people and so on. My view would be you need a funder that does not have a really strong hospital orientation. You need someone with more independence that can look across the population, take a bird's eye view and say, okay, this is where we need to invest. And, I'm really worried that we'll end up with a more hospital dominated system, and that's the opposite of what we need. And the point about, funding that Bryan made, absolutely. A great example recently, the big pay jolt for the nursing mecca that DHB's got, and I can't remember the amount, it was about $500 million, I think, that DHB's got so they could give nurses a pay rise. And they got no money to give to primary care organisations for a pay rise for nurses in primary care. And we've allowed a 10% or so salary differential to open up between hospital nurses and primary care and community nurses. And I think it's appalling. It's the opposite of what you'd want to have happen. So we need to get funding and commissioning outside of the hospital, whether it's through primary care or integrated care organisations or National Health Funding Authority or something. You've got to stop mixing it with the hospital balance sheet, in my view.
And Jackie, in your research, have you ever figured out why it is that hospitals and DHBs and area health boards and everything that's gone before ultimately don't seem to trust primary care?
Yes, that's a good question. I'm not sure I can totally answer it. But I suppose just putting this into context in relation to PHOs, many PHOs evolved out of independent practitioner associations, which were seen also to be very GP focused. And I think we've got an issue here about, what's coming first, because, a lot of those other organisations don't necessarily trust general practice. And therefore aren't necessarily going to join up with them in terms of being in a PHO until they can see something that looks somewhat more independent. And yet, as the others are saying, what we've done is funded PHOs in terms of that general practice function, kind of in particular. But a lot of the mistrust, I think, everybody's fighting for funding, which is in some ways crazy because we're a small country and pretty much everybody has a really important role to play in terms of delivering healthcare to the population. And yet a lot of our squabbles are over kind of funding and also, I guess, over control. Governments, as we can see, they come up with new ways of doing things every sort of few years, and they've never totally delivered on ensuring that funding increases at a pace which is actually going to keep the system actually going properly. And that is noted in the system review, that we need a new way of actually funding the system, which gives us a much longer term kind of focus. So I think that's one of the issues there.
Okay, so Zara, can we just see the results from that first poll as to who's in listening to us? And we're going to put up another poll about funding. Actually, Martin, can you just sit back because I can't see the results. Everyone out there will be very impressed with the very high-tech setup we have here. Troy Milford. So what an incredible breakdown. So we have health managers are the majority here, 28%, GPs 18%, pharmacists 12%, and there's a big group of others out there. Welcome to you lot. Okay, so we're just going to put up a poll. The next one's about what is the best way to ensure primary care is properly funded. So if you want to answer that would be great. We've given some random options. So I'm just looking at some more of our comments here. I think Tane Taylor has asked, after so many years with PHOs, does the public really understand what these acronyms and roles are? And I would say that's probably a resounding no. And the problem with people not knowing what you do is they don't notice when you've gone. Okay, so that's another question we've got here. Harley Ash has commented that some of the functions that some, possibly all PHOs currently provide, that DHBs don't have any expertise, such as practice-specific population health plans. Bryan, how have you managed with that kind of those kind of initiatives down in South Canterbury?
Well, I think that fundamentally the problem exists that people are talking about in the Simpson report, talking about ring fencing. Well, a hang of a lot of the funding that you receive is ring fenced to begin with. And your ability to adapt yourself and use that funding is extraordinarily limited, and there isn't a lot of it. And so you will have your health initiatives that are apparently funded, but the degree of funding that you receive for them is not actually sufficient to ensure that health initiative. And they're really there, I think, just as a political project that government can say that they've funded this, whereas in fact they want to acknowledge that they've inadequately funded this. And going back to what Jackie was saying a bit earlier, just with regards to how people and how our funding is arranged and whether it gets devolved into primary care and we have the equivalent of the UK CCGs and commissioning, it didn't work out for them. Let's just put it in that model. We might say, oh, here's a model we can copy. Sorry, it doesn't work. And general practice is in a whole lot of trouble, and the NHS is in a whole lot of trouble. So I think we need to learn from their mistakes rather than copy their mistakes. The issue is that, unfortunately, we have to submit any of our proposals for changes in funding to that ideas that we will come up and to use the funding that we've got. We have to submit that to the DHB and us. We have to submit that to ministry, and the answer is invariably it's turned down, and that is unhelpful. We have strong Maori representation within our PCA. And, we can talk all we like at the meetings. When there's no money to spend on anything, there is no money to spend on anything. And unless you shut down one program in order to fund something better, when the people receiving that funding don't want you to shut it down in the first place because they see some benefits maybe to them from doing it, it kind of creates this pull in all sorts of directions on a very limited pot of money. And having said that, our DHB also contributes to our primary care funding. So, the DHBs do this. I think that the fundamental problem is the level of funding that primary care receives in New Zealand, and you are not going to achieve the goals that you want to achieve on 1.46% of health spending. It's 8.1% in the NHS, and it's 34% in Australia. And you're playing behind the 8 ball here. So that has a big impact on what we can do and what equity we achieve.
And of course, the Simpson report wasn't required, or the Health and Disability System Review Panel were not required to go into the funding issue, although they did touch on it.
That's the fundamental problem.
Yeah, and but even I just wonder, with your experience, Martin, with DHBs and PHOs, how do you see, is ring fencing primary care going to make a difference, particularly if the amount you're ring fencing isn't sufficient for what you want to do?
Look, no, I don't believe in the ring fence theory. I don't believe that would make a difference. I've worked in DHBs and we had ring fences in mental health services. Great in theory and practice. It was more like a, what would you call it, a sieve, certainly a permeable membrane. I don't believe, I think you could drive a Hummer through any ring fence that they invent. I wonder whether actually what you want is more of a cap, a hospital cap, so that, we say, look, let's restrict what funding goes to hospital services. And I'm probably coming across as anti-hospital. I'm not. They're really important parts of the system, but running a hospital is a full-time job. I did it once and it nearly killed me. And you can't run that hospital and try and be a commissioner of health services in any kind of complex system.
We've got a question here around from Ian Powell actually about the new mega DHBs, presuming that they go that way, and being run by a national bureaucracy is going to create more distance between primary and community care. And I think Bryan's already pointed out how well they've managed to get the relationship working in a very small DHB with general practice and primary care. Jackie, what are your thoughts on the mega DHBs and reporting? I mean, could we not just have one and call it Health NZ?
Well, I think actually Martin's right about this in the sense that we're trying to do an awful lot of things with one structure, and a structure that we're sort of saying is going to be in place, you know, in 10 years kind of time, and it started from the top and then works its way down to the bottom, which means when you think about primary healthcare, the real worry is going to be, we set up Health New Zealand, we amalgamate DHBs, we do all this new planning, and I agree that it's missing some of it, but we could go overboard if we're not careful. And then eventually we'll get to primary healthcare, and that's going to be 5 years kind of down the track. And I think actually the better way to go would be to have a national primary healthcare kind of commissioning agency, which includes primary mental health care and primary dental care at the very least. And that way you could actually effectively ring fence the budget because they would hold it for that set of services. It would have to be a lot larger than it kind of currently is. And that would allow that organisation to focus only on primary healthcare. And then I would leave Health NZ and the DHBs off doing their own kind of thing in relation to the hospital side of it. I certainly wouldn't give the money for hospitals to primary healthcare. That's implying that our problems are in the hospitals. Our problems aren't in the hospitals. It's the extent and the way in which the primary healthcare system is set up, which is where our problems are. And I think I would have liked the report to say, that's where the issues are, let's start there, not do this big mega reorganisation and eventually get to primary healthcare.
I'm itching to interrupt you,
Yes.
Jackie. I think that the problem is in the hospitals. I think that the problem that we have in New Zealand is how we spend money. That what happens to drive health expenditure is, and they did this in the 1970s, they looked at why we have an escalating cost of healthcare. And they identified that the principal driver of the escalating cost of healthcare was doctors, and that we investigate and we spend money. So it's procedures and interventions that cost money. Now, what drives us doing those procedures and interventions? It's our own uncertainty. So we perform procedures and conduct investigations that cost a considerable amount of money, that gain more and more expense over the years, and actually don't deliver anything to the patients themselves. So we are, as a system, determining what the outcomes should be, rather than allowing our communities to determine what the outcomes should be. Now, if you start to push that further up the tree, to the level of ministry, you further distance your community from the involvement. So what you should have is a system where doctors are not doing unnecessary investigations, and they need to be, and not have some guideline that's generated by some interest group that says you have to have X, Y, and Z investigations before you can do a procedure, because most of the time you don't, and in a general practice level you don't, because you recognize there's a limited resource. But the hospitals don't recognize there's a limited resource, and they blame it on the system. And in fact, they are the system, and they don't want to change. So that's a fundamental change that has to occur in the health system. And you can move the deck chairs around all you like in terms of how that funding follows through, but it will not make a difference to the outcomes for the patients, because it hasn't made a difference. So the structures that we should have is multiple points of entry for patients into the system that may not be determined by a GP or by a doctor. It may be a social worker who sees a family that, or a person that has a need, that can actually refer to a GP or to a specialist, or even if it's to a specialist through a GP, but that actually feels empowered to actually be able to point out, and all these NGOs that can do so. And we don't have a model that embraces the input that they can put in. And that's what we're trying to achieve. But again, the fundamental issue is everybody's trying to protect their little pot of money, and they view these things as a threat. And what we have to do is change the paradigm rather than how we spread the thing. We have a hospital-centric, doctor-centric paradigm. And as long as that remains, you can change the deck chairs around as much as you like, we're going to sink. It's just gets more and more and more expensive.
Yeah, Sorry,
Sorry,
I don't.
right. Sorry, you're here,
Yeah,
Jackie.
I don't disagree. I just think that, you know, having one organisation or set of organisations trying to sort all of that out is incredibly complicated. And what I would do is have Health New Zealand doing that part of it with the hospitals, and something on the primary healthcare side, strengthen.
Somebody's got to coordinate it.
Well, I think more coordination's got to happen in primary healthcare, and we have to get that sorted.
More
And we're then
coordination in what way? I sit in primary healthcare and I coordinate people's health every day.
A
Right?
wider set of services.
But not all things can be coordinated by me. But the fact of the matter is, at a DHB level, they try to. As a PCA, we try to coordinate those. And it doesn't help when ministry rejects your proposals.
No.
It's interesting. You've kind of raised a point in amongst all that, Bryan, that one thing the Simpson report doesn't really look closely at is the patient.
No, it doesn't look at the patient at all.
Yeah. And so anyone outside the health sector reading this would probably have no idea or get no clues from it as to what it's going to be like to be a patient in 10 years' time in New Zealand. And there is a question here from Sean Hanna. How do you think the Simpson report stacks up with ensuring Māori health and equity is addressed, and how Māori health is funded, particularly with Y2575? And we are on Thursday night this week, we are going to be looking at the issue of the Māori Health Authority or Māori Health Commissioning Agency. But that's a good question about how are these localities going to, embrace equity any better than the current PHOs have done. Not to say that you haven't, but
the issue of equity is having input from those communities themselves. So you're going to have variations between communities, and so with our Māori representation, they can identify what the issues are, and so you may put in place structures that appear to address equity issues for Māori, but it turns out that because we have a smaller Māori community in South Canterbury, that Māori don't necessarily want to go to those organisations because they are staffed by members of their own whānau. And that's not quite what they want, because there's somehow this is going to, they fear that this might be, you know, shared amongst them when they don't want it shared amongst them. So those are the sort of subtleties that you've got to address. Now, I fail to see how large locality committees are even going to pay any attention to that issue, whereas it's a fundamental issue for us. How do we make sure that they have input into the care they receive and feedback from them about the care they receive, so that we can improve their future care that they receive, both at a general practice level and at a DHB level?
Okay, well, questions come in from Helen Parker, and it relates to the issue that in terms of the commissioning of services that we do. Is the commissioning leadership and skill that needs, is it the commissioning leadership and skill that needs reforming? And I think that comes back to an issue of capacity within the whole health system around contracting. I mean, some of that capacity has been built up over the last 20 years by PHOs. And as someone who's observed the health system for quite a while, I haven't seen the same degree of capacity built up by DHBs who are actually commissioning these services. Martin, is this something that you've, I mean, have you seen an improvement in the way DHBs approach primary care in the last 5 years, last 10 years?
I think it's idiosyncratic and inconsistent. What I see is that some DHBs provide a stellar view, and it's based on individuals, and a lot of DHBs do not have strong commissioning functions at all. In fact, most of them don't, I would say. One of the things I liked in the minority view of the Simpson report was the idea of a stronger Māori Health Commissioning Authority. I think we need stronger funders in the system. We're a very provider-dominated system, and I think that could improve equity. I was not unhappy with some of the ideas around locality. But the devil is it completely in how it's implemented and the detail. The idea is fine, and I think the idea could contribute to equity if we can get disparate people working as a team, and if we can start to work on, you know, socioeconomic determinants of health and some of the things that make, you know, that contribute to inequalities, then that would be great. But how is really hard, you know, like it's not, it's easy to write down. It's like this planning. God, the number of plans proposed. We need fewer plans and more implementation.
Yeah.
It's interesting because one of the, I suppose, most telling graphs in the entire report was the body, and showing that, you know, 20% health services contribute to 20% of health.
Yeah.
And to health system at the moment has very limited access to the other 80%.
Well, I mean, we sit, and again, I'm going to go back to our model. How many DHBs, PHOs, have the CEO of the DHB as a regular attender of their meetings? How many PHOs have the funding and planning manager of the DHB as a regular attender of their meetings? Because we do. And hence, when the CEO hears of ideas that can contribute to the services that the hospital provides and improve its efficiency, there's a direct input and the funding is provided. So there are service, that level of, and then you have people from the community coming to us and telling us what the issues are that they deal with, and we look at how we can, you know, change that. You have models of care that are out there that they seem to work, but this question is whether they really do work for everybody. And you don't get that by distancing yourself from the patients and the community. You get it by moving yourselves closer, looking at those. One of the biggest issues that we actually have is trying to persuade secondary care to let go of its funding. You know, in terms of, they will propose how we spend our funding to relieve their workload, but they won't give any of their funding to relieve their workload.
Actually, that's Gerald Young here in Auckland has just posted a comment. One big problem I see is that DHBs are not funded for stuff that they don't do, only on stuff that they do. GPs are busy doing stuff, so DHBs don't have to, but it's not measured at the moment, so it's zero value. It's a really good point. And I think if COVID has shown us anything, it's been the confusion around, you know, the funding for the CBACs, and then for the testing and the surgeries, and the inconsistent approaches. It's been quite telling when it comes to the public, you know, the DHBs wanting GPs to do stuff and how they go about, you know, doing that. Anyway, so let's just have a look at the results of our poll. What is the best way to ensure primary care is properly funded? No, so 49% put the new national agency Health NZ in charge of funding primary care directly. So that's essentially making it a primary care commissioning agency, which is kind of similar to what you were saying, wasn't it, Jackie? And 20%, 21% ring fence the funding and keep DHBs away from primary care altogether. And there wasn't that much support for putting primary care in charge of funding hospitals. So I think, was it Martin raised that point as well. So fair enough. Okay, so where are we at now? So we've got another 15 minutes, just keeping an eye on the time since we started late. Now, just looking at the questions we've got here. In response to Jackie's proposal to have a national primary care organisation, we want to do a great job in primary care to save money by reducing hospitalisations. So I contend we should have a single system. So that's from Ahaliash. So that's kind of where we were at before with the not splitting it up into all the separate bits. That doesn't help very much as a question, does it? For me, I've covered that. So PHOs, so these localities that we've touched on it a little bit about the fact that there's very little in the Simpson report actually detailing how they might work. It's kind of goes back to what happened with the primary healthcare strategy in the same way, in that the PHOs, there wasn't much detail about how they would specifically work. And as Bryan mentioned earlier, essentially they were thrown under the bus, set up to fail. Is that retrievable? I mean, even because one thing I looked at again at the report and I'm thinking, when I was looking for that wow factor, I was thinking, okay, so we're still going to have DHBs, we're just going to have 8 to 12. we're still actually possibly going to have PHOs because they are still there as an option. They're not necessarily, if they can, get the contracts, they can carry on. We're going to have a Health NZ, which is like going back to either the National Health Board or the Health Funding Authority. We didn't kind of push the boat out with the Māori Health Authority.
You're sounding underwhelmed, Barbara.
And it's like, this is 2 years in the making, and I really...
I feel underwhelmed. I'm grossly underwhelmed by the Simpson report.
So I'd like someone to tell me what they see as a real positive from this report. Anyone?
Well, it's done a really good job of, there's a lot of information in there, great for me because I teach, so heaps of information, that's fantastic. I think it did do a good job of putting down some of the issues. I think somewhere it's got lost between the interim report and the final report. If we remember in the interim report, one of the issues that seemed to worry the review panel members was that New Zealand didn't have this view of everyone working in the system feeling like they work for the system, like the NHS. And I think that's where the idea of Health New Zealand and linking the DHBs with that actually comes from. But it's not necessarily that clear in the final report why you've got this Health NZ body. The only comment that's made is that sort of running or organising the DHBs a bit more, so we've got a bit more consistency, is a set of skills that the Ministry of Health doesn't have, so therefore we need a new body to kind of do it. But so I think that part of it's kind of, it's not that well thought through. And I think the other part of it is it's seemingly, it looks like it's looked ahead, said this is what the system should look like in 10 years time, rather than where are the real issues right now and what do we need to do to solve those. And I think that's where it's kind of got tangled up.
It didn't look at where we're failing. And fundamentally, the issue is ask, don't tell. And we still have a health system that's based on tell, don't ask. And until we have that attitude changes within the health system, you can throw all the money in the world at it. It's not going to improve outcomes for those who have inequity.
Can I make a comment on that, Bryan? I like the sound of your alliance, and I was really interested that the review report says let's get rid of alliances, and with very little kind of analysis about that.
But the Simpson report went and asked the DHB and not the members of the alliance.
Yeah, I think you're right, and what it kind of talks to me of a movement back to command and control. Alliances are about partnership and working together for a common cause. And we could have more people in the partnerships, but instead the idea is go back and just do what you're told. And command and control does not work in health.
Yeah, it's interesting because that's the other thing with having multiple DHBs is when you talk about habit. I did like in the interim report about this idea that we needed a New Zealand health system where people feel that's what they work for. Yeah. It was a really good idea, the culture. Nice. But, look at our rugby teams. Not that I'm a great follower of rugby, but, if we have 2 DHBs, they will still be competing against each other. So whether we go from 20 to 8, 12 to 8 to 6, we look at the RHAs, we had 4 of them, and they were all completely different human resources approaches, different cultures, and I still kind of don't quite understand if that's what they were after, a culture that was at Health New Zealand, why have they carried on with the multiple DHBs?
Nobody's articulated what our health system should look like in terms of outcomes for the patients. Yeah. They haven't developed a strategy. They haven't developed a goal. So they haven't developed a strategy, and they're making it up as they go along. That's like saying, taking your troops, sticking on the beaches of Normandy and say, get on with the job, get somewhere. Yeah, we'd like you to maybe end up in Berlin one of these days, but we're not sure exactly how you're going to do that. And you need to supply your own arms and ammunition. and frankly, that's the model of healthcare in New Zealand, and it doesn't work. And nobody's articulated what our goal is. And you don't articulate a goal without establishing what the problems are at an individual level, at a community level, and at a wider local and national level. I mean, we have far too many disparate organizations in New Zealand trying to develop and do the same thing. And there's no cohesion or coordination between them. Now, if we try to do that, we don't have to take away their little empires, because that gives them a sense of importance. But we do need to have somebody that sits and listens to them and says, how do you think that that would work? And is there an alternative view to that? And what about this? So that because you can do more with the money that we've got rather than trying to throw more money in it. But if you're saying that the fundamental problem with primary care is the cost of seeing the doctor, well, that's another discussion entirely. You know, but there's no plan.
There's a comment here from Pam Jackson. We need to think about a shared risk reward model between primary and secondary care, move away from fighting over the dollars and towards outcomes. And that was kind of what the alliances were set up to do.
That's what we're trying to do, yeah.
Yeah. There's an interesting comment here from an idea from anonymous attendee. Why can't we have locality groups attached to district councils made up of all primary health providers in the area and involve patients directly in decision making for that area, and leave Health NZ to manage hospitals? And that's kind of close to what you were talking about, Martin, putting those hospitals off in there, having a national network of hospitals that are under the, can't remember, the Ministry of Health or Health NZ, I can't quite remember. And then those integrated care. So having your health providers linked in with your district councils in some ways helps change that body. You know, we've got the 20% of health services. If you could actually attach your health services to other part, you know, housing and, you know, other aspects that district councils cover, that's kind of an interesting idea. Thank you, anonymous attendee. Okay, and then another anonymous. Do we need a Minister of Health or just a competent Director General who sits outside the political cycle? Well, it'd be a very brave Minister of Health who would appoint a Director General and not have some political control over the Director General. Although we do know the Director General is supposed to answer to the State Services Commissioner. But yes, that's...
I mean, ironically, Barbara, my favourite Minister of Health was Tony Ryle, and not for the reasons people might think. I mean, he basically came to us and said, there's no more money. This is all I've got. Do with it the best you can. And if you find something that works really well, maybe I can persuade Bill to give you some more. Yeah. But don't count on it. All right. And that was what we're told to do. It's just to get on with the job. Ever since then, every time you get an extra bit of money, it comes with so many preconditions that it's impossible to achieve. And the control still rests with ministry. So that idea, you know, that I mean, DHBs and PHOs were created so that the minister had less political accountability for the failures of the health system. That's the fundamental reason they exist. And anybody who thinks otherwise is possibly delusional. The fundamental reason was so that they didn't get blamed when things go wrong. And it's not like the old days where you had Harry Truman and a sign on his desk that says the buck stops here.
Yeah.
Everybody wants to deflect responsibility.
It's interesting, that trust, I think so much comes back to trust. And we haven't got anyone on the panel from Christchurch, but you know, back in the early days when the Pegasus Global Contract came out, there was a lot of, I think there was a lot of envy, obviously, about their global contract, but that was kind of based on was it the District Health Board? I can't remember if it was the District Health Board, the Regional Health, it must have been the Regional Health Authority at the time.
Or HA at the time,
trusting that group to actually spend that money wisely. And you just mentioned, Brian, about all the strings that are attached every time you've got any money that comes through. And that can only get worse when you have larger DHBs where the people in those DHBs probably have even less of a relationship with people in community care and general practice. And so the trust will not be there. How do you get over that, Martin?
Sorry, my mind wandered and I was thinking about when I was in Denmark, Barbara.
Oh, maybe that's a better...
Well, in Denmark, the local authorities have got kind of local groups where the local authority and primary care and kind of public health is an integrated responsibility. And they described to me some things that I think sounded actually really quite good and could work well in parts of New Zealand. You know, it's not the same everywhere, but in parts of New Zealand, I think working together with local councils could work quite well with a, you know, like an alliance type structure. And people are, I mean, what's the trust equation? You know, the trust is based on intimacy, common purpose, and eroded by perceived self-interest.
Trust equation. Oh, I'll have to note that one down. So with just going back to your European sojourn, we often look to England in the NHS, which is obviously not in a good state at the moment. Was there anything that you would borrow from that if we were going forward into in terms of patient-centeredness? I think is where I want to go with that.
Well, look, my comment would be that it's a bit like when I went to the US, and you wouldn't copy the US health system or their political system, but there are bits of the US that are just startlingly good. You know, there are some really nice shining examples, and I think the same in the UK. You see some really nice kind of places where people have got together and made quite a big difference in local areas. The overall system is really overly controlled. It's one of the problems. You know, they've got a real strong command and control structure. So I wouldn't copy a lot of what I saw in the NHS, but some things, yes. I thought some things
actually, I shouldn't be asking that question because I really do think that we've got lots of really good examples here in New Zealand, and often it's actually finding them, and part of our job is reporting on them. But often people just, you know, they don't shout out their successes as well as they probably could, and that's possibly a problem when it comes to someone like Heather Simpson walking around the country trying to summarise what's happening in the health sector.
Oh, look, think about COVID, and I mean, primary care worked its butt off in the COVID response, and I think made an enormous contribution to things, and yet it was almost invisible, our contribution. I don't know what Bryan thinks about that, but I think that's the case.
Our contribution was ignored, I think, fundamentally. I think the original plan that came out of ministry was to throw general practice under the bus with COVID-19. And yes, because they said, yeah, the answer, if we get COVID-19, New Zealand is go and see your GP. Yeah, that will work out really, really well. Just ask the Italians. And it wasn't and I mean, we had a locality meeting about this, and we said this is really not a good idea. And you know, the DHB listened, and I mean, we had our CBAC set up, or being in the process of being set up before anybody else did. We had the nursing, the rest times listening, even when they were being told that they were violating patients' rights by quarantining themselves. They actually asked the patients and their families and their staff about whether they thought it was a good idea to quarantine themselves. And remarkably, you know, everybody seemed to think it was a really good idea to quarantine themselves, given the nature of the threat. I mean, as somebody said, you know, I heard an American commentator on talking about New Zealand's responses. New Zealand got told there was a threat and responded like adults. And that's New Zealanders. And the Americans, they responded like a bunch of kids and complained about everything that it was going to, and said, no, I'm not going to do this. Make me. And that's the difference between us. I mean, I think that we have a remarkable community. I think that the New Zealanders are remarkable people. You look at the response of the locals in Christchurch to the quake in 2011. You look at the initial response from the DHB in 2011 is that you can't trust the people and you can't trust primary care to deliver these services. And I went up there to help out, and we were hellish restricted in what we could do, but it lasted 24 hours. When they suddenly realized that actually they were doing it, people weren't overutilizing the resource, and we were delivering and managing the system. But it was thanks to the local population that was achieved, not thanks to the health system. It was the local people who did that. And I think we need to trust New Zealanders that when they tell us they've got a problem, that we listen to them, and if they've got an answer to how they can solve it, we should listen to them. We have a terrible attitude in New Zealand with the Chardonnay socialists that end up running our country, is they sit on the veranda drinking their Chardonnay, telling everybody else how the things should be run, and never once asking or listening to the people themselves. You know, and the answers are out there. You just have to ask them. We do this on a regular basis at the PCA, and the ideas that are forthcoming are some of them are quite, you know, outstanding. The problem that we face is, how do we make them work, and where do we find the funding to make them work? Because we're robbing a little bit of this and a little bit of that to try and put that in there, but we can still accomplish a lot of those things.
When it comes back to funding, then Liz Stockley has just posted a question. What would the panel have liked to have seen in the review as the basis for a new primary care funding model? Jackie.
So I think, you know, a lot of the issues are around, I think as Bryan has said before, it's around the scope of services. So it's been saying we need a much broader scope of services delivered primary healthcare settings and new models of care, and actually a broader range of models and more choice for people at community level as well. So I think something that would have acknowledged that, and then also talked about, you know, what does a fair funding model kind of actually look like, and it isn't what we have at the moment, and the capitation formula has been a problem from day one, and things have really only got worse. That's in terms of the distribution, but it still needs to be a larger pool of funding to cover a wider scope of services.
Martin, what are your thoughts on?
So two things. One is, as Jackie says, the quantum. So they could have put in a target, you know, let's get up to 10% of the health budget being spent on primary care services and preventative services. That would have been great. But also we know there are things we should be doing in terms of complexity and ethnicity to address equity of funding, and we can do that as well.
I mean, my only hope for the funding is that they'd actually maintain the value as they promised to do in the first contract. and that's the fundamental problem. If we weren't 50% behind what we were receiving in 2004, we wouldn't be in this mess. That every year what has happened is the increase in funding has been lower than the rate of inflation, except for the last 2 years. Now, I'm sorry, but those increases above the rate of inflation don't nearly compensate for 16 years of underfunding. And this is where you can't suddenly, unless you want to put an extra 50% into primary care funding, which, by the way, wouldn't be a huge chunk of the health funding.
Exactly,
anyway.
We could do it.
We could
right.
go back. We could go back to what we were doing, and we could re-envision the model, because we would be less going, oh, you've made it more restrictive for us by putting all these other things. We've ignored the negotiation opportunities that have arisen in those previous 16 years. We've allowed ourselves to be walked all over during that process. We've added complexity to the system. We've added and compliance costs to the system, which contribute nothing to the outcomes, but distract from the important stuff, which is, you know, making sure that the patients receive adequate health care.
And of course,
irrespective of their, carry on, sorry.
Of course, you know, this relates to all the other primary care clinicians as well, to midwives and pharmacists and, you know, physios and all the other people working who have the same kind of constraints put on them in terms of the funding they receive. Tony Becker, I think he's down in Martinborough, I recall, has made quite a nice comment. DHBs are funded for measurable outcomes, i.e. outpatient appointments, number of surgical procedures, etc. GPs produce immeasurable outcomes, i.e. improvement in health, improvement in mortality and morbidity. These future events are invisible to DHBs. This is why it's always difficult to argue for improvements in GP funding. I think it's a really good point, that invisibility. I think one of the most visible things that general practice has done in the last few months was the amazing turnaround over that weekend before we went into lockdown, from going to 70% non-face-to-face consultations, telehealth, which is just, you know, I really take a shout out to all of you for that. Now we've just got another poll here. If your DHB, or if your PHO does disappear, what would you miss? So if you want to have a look at that poll, it's up there now. Oh, it's been going. Okay, you've answered. We've got the results from that one already. Oh, good on you. So the results are, let's see. What would you miss most? Well, you wouldn't miss peer review meetings. Support for new initiatives. That's good. And then that support for new initiatives, 34%, but unfortunately 27%, nothing, pleased to see it go.
And that's a fundamental problem, because
Yes.
why would you be pleased to see it go? I mean,
Yeah.
that's why we wanted it gone, is because we did not feel represented by our PHO.
Yeah.
And because they weren't forceful enough. And what we got through a lot of head banging, because it wasn't an easy birth, all right, was a system where, because we had so much conflict, we started to listen to each other.
Oh.
Because that's the only way you resolve the conflict, is to listen to each other. And we were fortunate in terms of our current CEO is a really good listener. And you know, we dread losing our CEO at South Canterbury DHB, because he's a good listener. And I mean, that's my biggest fear, is that loss of contact with the change in the structure, and the loss of contact with the health administrators, who bring a different perspective. But that is equally important, because the money is important and how we spend that money. But it's about having those communications about, if we can think of doing something better. If a health minister comes to us and said, if you can work out something better, all right, that doesn't cost any more money, go for it. And if it really, really works, I can maybe get you some more money. That's the job of the health minister. I mean, his job is to facilitate improvements, not to dictate what you should do. And because we're quite happy. I mean, this is what the health system tries to accomplish. But when it's constrained by somebody else's ideology, it becomes more difficult.
And we've just had a comment from, I'm not sure if it's the same anonymous attendee. I don't know if that comes up as a generic, but I work both in GP, in general practice, and in a DHB, and it is breathtaking how impossible it is to get anything done in secondary care compared with how primary care operates. Small, nimble, quick to respond, quick to drop ideas which plainly don't work. I heard Ashley Bloomfield describe the, quote, implementation dysfunction at the Ministry of Health. It is widespread throughout the system. It's an interesting, I wonder, Martin, just thinking about, you know, the problems that general practice, I mean, that's obviously part of the majority of PHO membership, but localities, by bringing in all these other groups, which are, you know, is a fantastic ideal, you know, many of them haven't had the experience of contracting to the degree that general practice has had, or relationships with DHBs. I think a lot of them, some of them still work on the equivalent of Section 88 contracts. That's going to be a huge, huge learning curve for those clinicians and workforces. That would be quite an interesting challenge if you were looking at working in the localities arena.
Yeah, I think it will be a challenge. I think primary care is more nimble and agile and can get things done quickly. I think that overall, though, that could work well. I think people are ready to try something different. I think, you know, midwives and aged care sector and pharmacists are ready to take a different approach. I feel like there is a bit of a groundswell. So I am forever optimistic.
Well, that's good. So I'm just going to turn to my colleague here, Martin, and ask him, what is the time?
8:21.
8:21. So we've got you in a bit late. So I'd really like to come down to some closing comments. And I think Martin's point about being optimistic. Jackie, what are you optimistic about with regard to the, well, I mean, I suppose these are recommendations. So we should have some optimism, maybe. The transition committee is being set up to look at the implementation. So there's still the possibility that some of these recommendations may change or may not be accepted, or.
Actually, I think that's where the optimism would come from me, is that, you know, a different group would look at this and actually have a really solid think about its implementation and how something like this would be implemented in the order in which you do it, and really, you know, whether setting up a whole batch of new structures like Health New Zealand, amalgamating DHBs, is really going to be worth it, both in terms of time, how long it takes, and resources. So that's where my optimism kind of comes from.
So I'm just going to, just on that note, because I've just had a question come in from Anna Mickle. And that's around, because there's a whole chapter in the Simpson report on health IT. I mean, that optimism, a lot of it will lie in making sure those health IT solutions come through in terms of integrating the system.
Yes, but I mean, it's hard to be optimistic in that area. We've had so many
Yeah.
goes at saying we've got a real problem here and we cannot seem to sort it out. Now, I'm not an expert in that area, but there's something seriously amiss going on in that space. Yeah.
Yeah. Bryan, how's your connectivity down in South Canterbury?
Well, I'll say I was extraordinarily optimistic about the future of South Canterbury until the Simpson report came out. Because we were tasked with coming up with a 5-year plan as to what we saw for ourselves and how we would engage and integrate. And frankly, it's gone.
Yeah.
And you look at it and you say, well, we were building a model. We were the people who were listening. We were trying to find out what our communities, we were looking at even the hospital admissions, where if they were coming from certain areas, where there was inequity in those areas, how we could address these things. That's dead. You know, now we're looking at, can we have an effective handover to the locality commission? That doesn't fill me with optimism. It distances my community from their healthcare. And so I find it very hard to be optimistic about the issues there. But I mean, I was very optimistic about where we were going. We have a very committed group of very enthusiastic individuals and a passionate DHB and DHB board delivering healthcare. And they're threatened with extinction. And so are we if they go. Don't ask me to be optimistic about them ending. You know, wherever they end up, they should have stayed in South Canterbury, because I say to my patients, if you're going to get sick in New Zealand, get sick in South Canterbury, because it's the best place to get sick.
It's where all my in-laws live, actually. So, Martin, last optimistic moment.
Look, I feel like I might go away and have a drink after this. Bryan, my advice is hang on to the good things. You know, like this stuff, this reform will go on for years and it'll be chaotic. And in the meantime, you know, it's like life happens in the meantime between reports. So
this is what I'm hoping.
You can just keep doing what you're doing. Don't worry about it. And that's what I'm planning to do in the PHO. Yes, PHOs are optional. Fine, they've always been optional. You know, if we're not adding value, then get someone else to do it. And so we just keep working on trying to do a better job. That's my view.
Thank you. Look, so thank you so much, guys, for joining us tonight. And thank you for all you out there in the ether. And for the people who put their questions forward, I want to do a shout out to Jonathan Simon, who I see has kind of zoomed in from the UK. And I'm sorry about the delayed start, and we've got another another Zoom meeting on Thursday night looking at the Why Not Māori Health Commissioning Agency, and then next week we're also looking at general practice, and then the last one is on DHB, mega DHBs and Health NZ. And in all likelihood, I think we will try and do a few more because I do think it's really important to keep these conversations going. And if the sector has, this is the only way really the sector can kind of influence now what's come out with the report. And I'm optimistic that it's possibly not too late. I think something can change if, you know, and given that so many people have registered for these panels, I'm optimistic that people are actually interested in talking about it. So thank you so much, and hopefully we'll see some of you back on Thursday night. Thank you.
All
right.
Bye.
Thank you all. Thank you very much.